The refractive outcome of a cataract surgery, as you have heard our first speaker said, depends upon the precise and accurate predictions of the power of the IOL to be implanted after phacoemulsification. To optimize the accuracy of predicting the post-operative refraction, various formulae have been developed to calculate the IOL power. Good surgical technique with low complication rates, of course, is of paramount importance, but biometry is the most critical factor in obtaining the expected refractive results. Biometry is defined as a process of measuring the power of the cornea, keratometry, and the length of the eye, the axial length, and using this data to calculate the power of the IOL to be implanted using various formulae. Keratometry can be done using manual, automated, or topographic methods. Appnation tonometry or gonioscopy has to be avoided just before doing the keratometry because, as we all know, it distorts the Myers. Care should be taken to get accurate K readings, as a 1 diopter error in K values leads to a 0.9, almost equal to about 1 diopter error in the IOL power calculations. In axial length measurements, there are two methods of measuring the axial length of the eye. One is the acoustic biometry and the other is the optical biometry. In acoustic biometry, ultrasonic waves are used along the optical axis of the eye to measure its axial length. In optical biometry, partial coherence laser interferometry measures the axial length along the visual axis of the eye. Ultrasonic biometry may again be performed using two methods. The contact, where the ultrasonic probe is placed directly onto the cornea. The immersion method, where a water bath is used so that the ultrasonic probe does not come in direct contact with the cornea. What do you mean really by ultrasound and the waves that are produced? Sound frequency between 20 Hz and 20,000 Hz is audible to the human ear. When the frequency of sound is greater than 20,000 Hz, it is not audible to the human eye. We call it as ultrasound. Most of our A scans and our B scans use a frequency in the range of 10 million Hz, where the penetration probably will be a little shorter, but we have excellent quality. Ultrasonic waves travels faster through solids than liquids. This is an important principle as the eye is composed of both solids and liquids. The speed of sound through the ocular tissue will vary with the density of the tissues. Denser the tissue, faster will be the wave it travels through it. Speed travels through the various portions of the eye, especially the cornea. It travels at the speed of 1641 meters per second. Aqueous, it drops down to about 1352. As we all know, the aqueous is little more less denser than the cornea, and it jumps back to almost about 1640 in the lens, and when it comes to the vitreous, it comes back to 1532. In A-scan biometry, one thin parallel sound beam emitted from the probe travels from the cornea to the sclera, bouncing back to the probe portions of the beam as it passes an interface. An interface is a junction between two media of different densities and velocities. In the eye, we have multiple junctions and interfaces. We have the anterior cornea, there is the tear film anterior corneal interface, the posterior cornea and the aqueous interface, the aqueous and the anterior lens interface, the posterior lens and the anterior vitreous interface, the posterior vitreous and the retinal surface, and the choroid and the scleral interface. The echoes received back into the probe from each of these interfaces are converted by the biometer to spikes arising from the baseline. Greater the difference in the media at each interface, stronger are the echoes and higher are the spikes. If the differences at the interface is not significant, echoes become weak and the spikes are very, very short. No echoes are reflected if sound travels through media of identical densities and velocities. A typical A-scan measurement will show a tear film of about 3 to 5 microns, cornea about 500 to 550 microns, the anterior depth of an average of about 3.15 millimeters, the lens measures about 4 millimeters, vitreous about 15 to 16 millimeters. Totally, we have about 23.5 to 24 millimeters across the globe. The contact biometry. This contact biometry has been the choice of biometry for the past 2 to 3 decades. It has been giving us excellent results and consistent results for the past 2 decades in the hands of expert ophthalmologists and expert technicians. But of late, things have been going wrong. It started giving wrong results and variable values because probably more and more inexperienced and casual examiners are doing the IOL power calculations and biometry. The tracing seen on an A-scan unit represents the intensity of the wave reflected back to the probe by various interfaces that are passed through. The highest intensity will be achieved when the reflected wave is perpendicular to the direction of the travel of the sound waves. Thus, the spikes seen will be low if the probe were placed oblique. The more perpendicular the probe, higher will be the spikes. Spike height is also dependent upon the power or the gain applied to the vibrating crystals that generate the sound waves. The more the power or the gain, the higher the spikes are recorded. But overdoing it, by having too much of a gain, spikes becomes blur and merge into one another. If the gain is too small, they will miss many of these interfaces. The reflected waves are also affected by the microscopic irregularities on the surface from which it is reflected. In macular edema, the surface of the macula is irregular, which scatters the sound waves more than the normal macula, thus altering the heights of the retinal spikes. If the spikes from the retina is not followed by multiple small spikes, it means you have hit the optic nerve, and such a reading should. One of the most common errors in the measurement of axial length with contact biometry occurs because of the operator has a heavy hand and pushes the probe too heavily against the cornea, indenting it, thus shortening the measurement. This is important because for every 1 millimeter of error, the IOL calculation goes off by about 3 diopters. To overcome this, probably the iatrogenic error of axial length measurement, the immersion biometry has slowly evolved. A Prager shell placed between the eyelids, filled with saline and immersing the probe into the fluid, avoids the contact with the cornea. The axial length with the immersion method is 0.17 millimeters longer than the contact lens method, even under expert hands. On calculation, probably it works up to a very, very small amount of 0.25 diopters IOL power calculation. I'm stressing this again and again because the care and the experience in taking this A-scan biometry with the contact and the immersion biometry is very, very important. In the case of amateur hands, the variation can be very, very disastrous. The immersion technique allows the probe to get its measurement without actually touching the surface of the eye. With the immersion technique, generally more accurate measurements are obtained. Eyes measured with the immersion methods are, as I have told you, 0.1 to 0.17 millimeters longer than measured by the contact lens method. Corneal spikes will have 2 peaks corresponding to the epithelium and endothelium of the cornea. If both peaks are not equal height, the sound beam is not directed through the corneal vertex and therefore is not aligned along the visual axis. Discard this reading. This may appear cumbersome to the examiner, but reduces the technician dependency. This classically shows the presence of classical appearance of the twin corneal spikes representing the front and back surfaces of the cornea. Recline the patient in a comfortable position. Proper placement of the probe is in the Prager shell with adequate fluid. Maintain perpendicularity into the corneal surface. Patient should fix at a distant object with the other eye. In the normal eye, an error of 1 millimeter axial length will result in an error of 3 diopter post-op. Longer eyes are more forgiving, but shorter eyes are least forgiving, and probably the errors can jump even to 3.75 diopters. Long eyes, when the sound beam is not perpendicular to the retinal surface, post-operative refractive error is in the hyperopic directions. Variations between the right eye and the left eye, if the axial length usually is about 0.3 millimeters, unless the patient has other conditions like anisometropia, keratoconus, or posterior staphylomas. Of course, scleral buckling surgeries, corneal transplants, refractive surgeries may also hide, lengthen, or variations in this two eyes can be seen. Various tips that we can give. Check the anterior chamber depth when the average is about 3.24. If the anterior chamber depth reading is smaller, then we should confirm it clinically even before the surgery. The average lens thickness is about 4.63, but can change with cataract and age. K readings are usually in the range of 42 to 43 diopters, with one eye typically within a diopter of each other. Correct IOL placement by the surgeon is mandatory. Various formulas are used. Using the correct formula is utmost important for the best surgical outcome. Third and the fourth generation formulas are more accurate. The holiday do is generally emerging as the most preferred formula, irrespective of the size of the eye. But the standard that we all like to use is the SRKT formula. Of course, the shorter eyes uses a holiday 2 and the longer eyes use the SRKT. Factors which affect the IOL power calculations are the wrong axial length measurement, the wrong ultrasonic frequency that you set onto your machine, a wrong keratometric value, you choose the wrong formula, a wrong surgical technique can be in the bag and the sulcus, or wrong orientation of the IOL optics. Why do things go wrong? Because of the corneal compression, as I've already told you. Misalignment, which is very, very common. Lack of training for our staff. No guidelines that is followed throughout the whole system. The reliance on other people to do these scans. The senior most optometrists will give it to the junior. The juniors will give it to the fourth year interns, and the fourth year interns will give it to the second year interns. There is no dependency at all. There is no follow-up of these people at all. People who are in a hurry. Technical failure, which is usually very rare. The human error is more common. A wrong A constant or a wrong formula, a wrong patient, the wrong eye, the wrong IOL, unforgivable. Always a series of measurements. Measurements should not vary by more than a few hundredth of a millimeter. As a rule, throughout the aberrant measurements, or better, repeat until you have no aberrations. Look for good spikes, perpendicular retinal spikes without shatter in front of it. Gain should be set adequately. Train and certify your biometric staff. Follow certain guidelines. Watch out for the unexpected and learn from your mistakes. A word of advice. The concept for calculation of IOL power for a particular patient must begin with a clinical understanding of the patient's future binocular visual needs. The most accurate A scans, formulae, and the technicians cannot recommend the IOL power most appropriate for your patients. This decision must always remain a medical one. Thank you very much.